Hello, I'm Dr. James Midboe, and I'm here at Finish Line Wellness. I'd like to welcome you to some of what we feel like is the most common rehab for injuries of today. So first I'll get into a little bit about my story, who I am, and what Finish Line is all about, how we came to that. And then we'll move into more of the more significant rehab that we feel like is relevant, especially in today's world, and tie it all down to how it's more relevant than just chiropractic alone, and why it's important in our everyday living for, I would say, most people. So again, I'm Dr. James. I'm a graduate of Northwestern Health Science University in Bloomington, and my story into chiropractic really began through a neck injury. I was 16 years old, so I think in going through school, I feel like that's a common theme. We see a lot of athletes that go to school for chiropractic, and their introduction to the profession was through sports injury. So much like many of us, mine was as well. So my intro, I was 16 years old, I was into sports. I played sports in a small high school community, and so being able to play was really important to even having a team in that community. And so when I was injured, not only did that put pressure on having a team, but also it just wasn't very fun to be hurt as well. So sought out different types of care. Medical care, like many people, was kind of the first option, and I didn't really find any relief. The neck injury I had was a nerve impingement, and outside of being in pain, it was just kind of awkward and embarrassing being in a stuck position everywhere I would go. And medicine didn't work. Tried the medical route and physical therapy, and just sought out a lot of other types of care that weren't effective for me. And family friends had tried this chiropractic thing, and I think it was 3 visits later, I had full range of motion in my neck again and no pain. So, like many of you, as a 16-year-old boy, for me, I was very conflicted with that. You know, how as an innocent kid was I not pushed towards this option even, and then almost felt like in a way it was almost like hidden from me. So I was very curious at 16 years old, like what is this all about, and how did it work for me, and then is there more to it? So I have a lot of questions, and like a lot of us, when there's questions, we want to fill the gap, right, with our kind of story of like, there's more to it, or what am I missing out on? And so I knew there was more of that, more of those questions to get answered. So when I entered into undergrad, I was pre-chiropractic already. I was set on this as a profession, but as a 16-year-old, when I was able to get back into sports, obviously that affected me in a physical kind of way, but being able to be back with my friends again and things like that, I saw the connections and how that was important to me from an emotional standpoint as well. So I just knew that there was a lot to it. And so once I started feeling better, which was in very short time, just a few visits, my coach said you should go back to the medical doctors and see if there's an option to maybe play again. So I was held out. I was told I was never going to play a physical contact sport again. And so I went back in, and they said, I remember them telling me, whatever they did, you're good to play again. And it didn't sit with me well. I feel like whatever they did just had more bearing to it. And so regardless, I was able to play again. And I remember asking, so like, can I play next season, or when does this start? And pretty significant injury, nerve impingement, and they said, no, you can play Friday this same week. So again, just really conflicted with how it could go from never playing a contact sport again to like you can play Friday the same week. So that's where my journey began in this profession, and saw it at an early age that it was just far beyond the physical and even just the pain component of it. Saw how it affected me from an emotional standpoint as well. So entered into undergrad as pre-chiropractic. I did a science background, so I did biology and chemistry majors undergrad, and went on to actually play college sports. So not only was I able to play in high school because of chiropractic, so I was not in pain anymore. I was able to play the sports, not just again, but the same season, because I was able to play that season, and then the following, I was able to get a scholarship to play football in college, which paid for my school, and met a lot of my best friends doing it. And then after college, did it for a job for a while. So then now I'm traveling and getting paid to do it. And so it just, chiropractic brought me to a lot of the more interesting people, and some of the best relationships as well that I have still to this day. So in chiropractic school, I think a lot of us have a similar experience where we get into it, and the school is very intense. It's very, by the book, gets you ready for boards. And I think what some of us kind of forget in the process, just because it's such an overwhelming amount of information, is how will this be utilized actually day to day in clinic one day. And so the interns that I see, and a lot of even the seasoned docs, we want to almost kind of like back it all down a little bit and get to like the bare bones. Like, what are some of the most commons in this, and make that relevant to our population, because we're going to see a ton of overlap in treating patients, and a lot of the injuries that we see are going to be the similar type of presentation, but from a different ergonomic maybe. So in today's focus, we want to focus more on the physical component, and we're going to focus on upper cross syndrome. So it's really kind of this idea of the neck straining forward. We get a forward head lean, and it really like rolls our shoulders around. So we see this in a lot of different professions. You got the hairstylists, you got the people that are driving a lot for work, desk workers. I mean, it's on and on. Computer workers, and so students, another one. So as a student, if you're watching this, especially the many hours in chiropractic school, it's kind of ironic that you'd feel a lot of these issues while you're actually going to school to treat these issues. So, but we see it often, and I remember some of my most difficult times in I guess injury were actually during chiropractic school. So it can be physically demanding to be in class and studying all day and night, especially for 3 years or more of that. So we'll see this, and those of you that are going to school or have already gone to school, you can definitely relate to it, because you've already lived this. But like me, I'm sure that you as well have a story about how the physical demand of this can cause an emotional connection as well. And so that's something that we talk a lot about here at Finish Line Wellness is the connection, physical, chemical, and emotional connection. And we see it show up in all sorts of injuries. So not just like upper cross syndrome or but it's the sprained ankle, and the kid, the kid that couldn't play the sport, and the emotional trauma with that, and or it's the neck injury that caused a headache, and headaches can cause up to 80% less production at work. There's emotional stress from the boss, and so there's just all sorts of different scenarios and levels of it. But there's been no better time ever than right now for what we do as a profession. We look at the cost of healthcare, and we're paying more for it than we've ever paid. But like we say here, is that if you think the cost of healthcare is a lot, take a look at the cost of sick care. And we know that that's really, for one, it's the number one cause of bankruptcy. And so, it's on and on, but we're all paying more for it, and so the chiropractic profession and how it correlates the physical, chemical, and emotional relationship with dealing with stress. There's just been no better time than right now. So we as a profession, we need to stand up on that. We need to talk about the things that I think we're pigeonholed for as a profession, like pain, which is 6% of neurology, but also really understand, like, if we're affecting neurology and 6% of neurology does pain at that level, then what is the other 94% of that neurology doing? And that's function, right? That's how we function in our body systems, and it's a system that was first developed. So brain and spinal connection, and then all else is a relationship of that. So so how we look at it is if there's a relationship with pain, say at the neck, I want to know where else those nerves go to. So if there's radiating pain down the arm, I'm going to be considering that there's a brachial nerve plexus and a neck compression issue there, and I want to know more about it. If it's a low back problem, I might ask questions about bowel and bladder function. I might ask questions about your GI function, because the neurology from that level is correlated, it's overlapping. So how many people do you think we see with, say, like low back pain that also have a digestive issue? And how many times do you think we see an intake where somebody has, say, a low back problem, and we ask them about a digestive issue, and they just can't believe that we can correlate that when it wasn't even on the intake. So I think it's so relevant in our profession that we really start to tie those bigger issues together, because a lot of people maybe wouldn't see, say, a chiropractor for like a digestive problem, but we've over the years helped a lot of people with digestive problems, and some of that just as a byproduct of treating their, say, low back pain, for example. So there's been no better time. As a profession, we need to stand on that in what we do for not only healthcare, but for especially like the cost of healthcare. This is the time where we need to shine. So getting into most common. So back to kind of my initial introduction into chiropractic was a neck injury. Again, range of motion restriction. So what are some of the things that we would see with a neck issue? Again, a low amount of neurology elicits that pain response. So there could be early signs of, like, say, like range of motion restriction. You could have things like headaches are showing up, just muscle tightness in your neck. You could have radiating pain down your arm or arms. There could be, upper back pain just from the strain of that head being forward. A lot of people with a forward head carriage, we see issues with like issues with mood, focus, sleep, energy, thyroid conditions. So thyroid gland is in here in the neck. Issues with like ear infections, jaw problems like TMJ, and that is just a short list. So it could be there's a lot of symptoms that a neck dysfunction could lead to, but those are just a few of the most commons I would say that we see, but really correlating those together. So for example, like somebody with a range of motion restriction, like I can't turn my head this way, a lot of times would have another symptom. So if we treat it from a problem-based standpoint, we can get results in both of those areas or multiple areas just from treating the root of the problem. And so that makes this profession just so rewarding, but really like understanding how to both evaluate and then effectively treat, especially from a long-term stability standpoint, that type of problem. So in the neck, with an adjustment, a chiropractic adjustment, we can restore mobility very quickly. The long term is going to deal a little bit more with stabilizing what we mobilized. So, and if it's a degenerative condition, it might take more repetitions to get that area mobile, but once we get it mobile, then we got to keep it there. So stability is so important for that, and that's what we'll focus on today. So beyond just the adjustment alone, which we consider passive care, so it's just me, for example, giving the care unto you. So you can just show up, get adjusted, feel better, but you maybe had 30 years of retraining yourself into going back into that dysfunction, or like get adjusted in the morning and then you sit for 12 hours at a desk. You may, what we call retrace, you might revert back into or retrace back into that same forward head carriage, for example. And we see that so many times. I mean, that's, I would say, especially in the world of phones and iPads and just transport, just driving and things like that. I think it's just so common that we're seeing it more and more. People are coming in with more X-rays with a straighter neck, so lacking that normal cervical curvature. So it's becoming more, I would say, common from what we see on radiology. But it still just doesn't all of a sudden make it normal. So there's just more cases of it, and it's, I think, becoming a tech neck or things like that are becoming more of a common thing we see. It's just still not normal. And so, we're going to pay the consequence for that. And so it can show up in all these different kinds of symptoms. So if you come to finish line, how we're going to go about something like this and treating something like this is, of course, intake form, and that's really going to give us a lot of the clues about where to go and where to look. So if there's like I said, radiating pain, we're going to want to picture that, and if there's a long history, for example, or maybe even just a short history, but it's a traumatic history, we're going to want some pictures. X-ray is what we use here, but we're going to want to see like not just the dysfunction, but to what extent. So in taking x-rays for an evaluation, why that's so important is because what we say here is to see is to know, to see is to know, and to not is to guess. So we can evaluate a neck from an outside standpoint using range of motions and asymmetry and checking the temperature and all these different evaluation methods, but to see like a bone spur at a level is impossible from this standpoint. So that's where imaging is really advanced, and digital imaging has gotten so good where we can really understand so much about what's actually happening inside of us. So but onboarding is going to be more like an intake form. We'll get that history, we'll ask questions specific to that intake, all the things direct, how long has it been there, how often is it there, what intensity is it at, and it really is just going to lead us to the bigger issue down the line. So, and really it's all to find out pretty much these three things. Really symptomatically, how does this person rank? Structurally, just A to B, how far off is it? So if it's further off, we got further to go back. Because if we're really treating it from a problem-based standpoint, if you have a reverse neck curve, it's going to take longer to get that neck curve to come back to a normal curvature than a person that just got a slight lack of curvature. So symptoms, that holds the least amount of water, I'd say, in making a treatment plan. Structure, how far off is it? And then the last one is, I would say, the most kind of limiting in that, and that's the degeneration qualities of it. So if you have a lot of degeneration, so like wearing out of a joint, arthritis, bone spurring, discs that are bulging or herniated, it's gonna take longer to fix it, certainly. So, but really that degenerative quality and how that ranks, a lot of that's understood through imaging. So that's where, again, imaging is so important, and it's the most limiting in creating a care plan, because it's at some point there's a diminished return. If there's a lot of degeneration, we're gonna have a longer care plan and probably more frequency. So those, I would say, are the big three. So symptoms, structure, and degenerative change. Finding out most of that's going to be, of course, through an examination. So here we use different orthopedic tests, ranges of motion, palpation, and then also through history. So really what we're finding on exam, a lot of the where we would look is going to come through the questions that are answered about this person's history, and those questions are asked because of the intake form. So we want to tie it all together, and then by the time we take pictures, really we want to kind of have an idea of what we might see there, and really the pictures, I think over time we become a little better at, the pictures are more a confirmation of what we pretty much already knew. It's really just to what extent is the big kind of missing factor that we get out of that. So today's focus more on upper cross syndrome, so again, this tech neck idea, and it's very common that we'll see people that have this condition to have a straight neck. So a lack of a normal curvature in the neck. So that neck's either straight or lacking curve, either straight or even a reverse curve. Now the ones that are reverse curve, we're going to see degeneration accumulate very fast on those. So in other words, back to like symptom, structure, and degenerative changes. A reverse curve, probably more symptomatic, probably multiple symptoms, usually more severe in nature, and then either more degenerative or probably are going to be becoming more degenerative at a faster rate. And then they're just lacking that springiness. They're lacking that normal joint articulation to keep that hydration in the discs and to keep things from kind of binding to cause arthritis. So, on an X-ray, we'll see typically in the more symptomatic people a more straight neck. when we look at rehab for that, so the chiropractic piece of it, of course, adjusting. There's multiple ways to adjust. Activator. Here we use a lot of diversified technique and manually adjust, but all different types of techniques that work for restoring that mobility back. And then it's all about how we're going to stabilize what we just mobilized. So in stabilizing, we want to look at it from an idea of kind of talk about four main points. So in most people that have this tech neck or forward head posture or straight neck, we're going to see that when the neck comes forward, the muscles that retract the head, especially in the straighter x-ray of the neck, are going to be basically shut down. So these neck muscles really don't have to work very much to bring that head back. They're kind of just shut down, never really getting facilitated. And so we see a deactivation of the muscles that flex the neck back. When the head's out here, also we see that the muscles between the shoulder blades are also underactive, and so it creates this rounded kind of a posture. And a lot of times when you see people for this condition, when we start having them do rehab, they can't even actually like consciously contract that area. So it's rounded to a point of, and just the muscles are shut off, which is a neurologic relationship. But then the neurology is just shut off and trained, basically undertrained, to a point where they can't even consciously actually make it contract. So really in this neck area, deactivated. So you can guess that when we get to rehab, we're going to try to activate that area, and then in the upper back. So you can kind of just follow that, like what does that person look like, or what does my posture look like while I'm at a computer, and just kind of think it through. So these are the underactive deep neck flexors, and then between the shoulder blades is the underactive areas. The more hyperactive areas are, just think of that rounded posture, what creates that, and that's the chest muscles. So pec major, pec minor, and it's really just pulling that posture to the front. We'll get some involvement here in the scalenes and SCM muscles as well, but to focus on kind of the bigger items, that forward rolled posture is really a product of the pecs being too tight, and then the traps. So think of, again, somebody with the forward neck posture. A lot of times we'll see them with their shoulders. We say like the shoulders are in your ears, but the hiked posture of the traps, activation, levator, muscle and traps, and then activation here. So if you just activate those muscles, you'll kind of get the extreme of what a forward head carriage would look like. So it's the elevated shoulders and the rolled forward posture. And so you get this forward head idea. But you can see how that, that strain would cause a lot of issues here, especially over time. And kind of analogies, you talk about like the bowling ball. That's kind of I feel like a pretty good one, because like the weight of a bowling ball, 8 to 12 pounds, is about similar to the weight of a head. But even if you're a bowler, or have ever attempted to bowl, if you're just holding that ball even out like one more inch, just see how long you can hold it there, and your arm will get tired real quick. So now imagine, instead of just the muscles of your arm, think of your spinal canal being in there, and you put that bowling ball forward another inch, and you're creating a ton of pressure on the nervous system, which controls all these other functions. So it can be really debilitating, and that's why we see people with a forward head posture have a lot of symptomatic things. It's I'd say seldom just one thing that they're coming in for. If they're forward, especially a reverse neck curve, we're going to see multiple symptoms: radiating pain, typically muscle tightness, range of motion restriction, headaches, and a lot of TMJ, usually troubles with sleep, mood, focus, and energy. So it can really emotionally wear on a person if they're forward like that for a long time. And some people don't even realize they're in it. So this is a classic case of somebody that works, been working like at a desk for like many years, chiro assistant. So a lot of you watching this probably are going to have a chiropractic assistant at some point, or have had one for 20 years, and you can recognize that posture. When they start getting forward too much, they're really going to create some issues. And you never want to have a front desk person that works at a chiropractic office having chronic headaches and chronic fatigue because of their forward head posture. Right? You want to see them postured up and be an example of what we do and what we treat, what we believe. So at Finish Line, one thing that we do is we have a process of rehab where we call it a buy-in. So before shifts and or after shifts, we'll have the front desk not only getting adjusted regular, but also have them activating or stabilizing some of the stuff we'll talk about today. So real simple thing, you can keep a band, or for those of you watching that are just somebody that works with a forward head posture, cosmetologist, computer worker, somebody that's anybody that's forward head posture, or computer working, arms outreached, just to have simple rehab tools. So if you're reading an email or something, you can work on that stuff real easy while you're just actually still working. And there's actually a lot of different studies on having breaks of activity and how much that produces as far as outcomes in job productivity as well. So some of the more, I would say, extreme things are when people take like a work break and then they're doing like a jump rope or something like that, burpees. Everybody wants to do burpees at work, next to their cubicle. You see walking treadmills with a computer station on it, things like that. But so not only does it help with rehab, but it can help with the productivity of the office a lot too. So back to this upper cross idea. So the weak parts we want to make stronger, and the tight parts we don't really want to make weaker, but we just want to make them longer. So maybe not quite as hyperactive. So let's start with the deep neck flexor. So again, with the head's out here and straight, we want to bring it back. And so an easy way to do that, and you can do this about anywhere, is just retract the head back. So you're just using the flexors that are shut off. So it's kind of the opposite motion, but you're just going to retract. We call it like almost like using it like a double chin. But you're going to retract your head back posteriorly, and it's going to activate the flexors in your neck. So simple to do. A lot of times we'll have people do just like 5 seconds at a time, multiple times per day. I think in rehab too, the kind of, I guess, goofier or lifestyle things that you can connect with people on, the more easily they'll remember those. So one thing that I'll tell people often is to have them do 5 seconds of chin retractions every time they stop at a red light. So the driving posture is something that creates that forward head posture anyway, so it combats that. Also gets them to think about while they're forward and driving that every time they hit a light, they're perking up more, and they're doing something to counterbalance the forwardness about it. So 5 seconds at a red light would be a kind of a nice little trick to get them to start thinking about while they're driving. I've had other docs that tell patients with forward head posture just to adjust all their mirrors up, so it creates that, you have to sit up a little more posture during driving. So multiple times through the day of doing a 5-second chin retraction will help those neck flexors enough, and that, along with getting it mobilized, adjusted, you'll see a lot of results as far as changing neck curvatures. In the mid back, so looking at middle to lower rhomboids particularly. So where's that? That's between the shoulder blades. So not really on the top part of it, because that's a lot of times hyperactive. But it's really the middle to lower between the shoulder blades, and just really trying to get them to like fully contract. So think of it like if you were to put a pencil between your shoulder blades, you want to pinch that pencil and hold it in there. And so it's that kind of muscle group that's really needs to be turned on or activated. We call it facilitated. It's part of the posterior chain, so the back side of your body, and activating that. Very underdeveloped in I'd say most of our culture. So one way to do that, an easy way that we use, we just use a really light band, because like I said, most people that do this type of activity, they're so weak in it that they can't even like turn that muscle group on. And so not only do we want to turn it on, but we want them to have like a full contraction of those muscles. So it's not going to take like much of a band. So usually a light band is what we use. This is the lightest one that we have. And it'll work for all these cases, so at least to get you to a certain point. Also, if you're using too strong of a band, and this patient can't activate that group, then they're going to recruit other muscles that they can activate, and now you're working into the same problem that you had before. A classic example, I'd say, is like the big guy at the gym that is like lifting the whole stack of seated rows. but really just like recruiting other more dominant muscle groups just to get that. So actually still completely shut down in the back, but using other recruited muscle groups to get the weight lifted. So digress with that and use a light band. It's not going to take too much to activate in there. Most of us are under facilitated, so one easy way to get activation there is just I just cut this band. It came off a roll, so it's pretty cheap. You can get it in bulk. We usually always have a bunch of rolls of it around, and you can just basically put your shoulders down and back. I like to have people go palms up when they hold it, and you're just going to rotate your arms out like that. So just pulling the band out. So again, think of that idea of having a pencil in between your shoulder blades, and you want to pinch the pencil between your blades. So down and back, just like that. It's a bit of on the elbows, it's a bit of a pivot, so it's not so much like pulling the band like apart like this. That's a whole different kind of activation. But it's pinching the shoulder blades together, just like this. So again, back to the buy-in. So some of the desk workers here, they'll actually have this same band around the computer area, and when there's a break or if they're reading an email, you might see them, or before a shift, you might see them just doing repetitions like this. It counterbalances, it offsets that next hour, 20 minutes, 3 hours, whatever it is, of this forward staring at a computer and checking people in type of idea. So easy to do, get some thinking on rehab, and it's a simple activation. Also, again, back to productivity, having them do something in a manner where it's, maybe like jump roping isn't as relevant to upper cross syndrome, for example, where this is it caters to the very problem that their work environment is going to lead to long term. So activation repetitions, done this a significant amount of times for over the past 10 years, and I think that if you can get your patients or yourself to do 30 or more repetitions of this per day, that's going to handle most of these cases, along with these other rehabs and of course getting adjusted. But for this particular one, if you can get them to do 30 or more per day, that's going to be enough to usually activate that area over time. And you can get complex with it and add different things and add a heavier band if you want, but usually it's not necessary. Usually it's just the 30 or more per day, and if they have problems and you want it to go faster, then they can pull on this a whole bunch more times if they want. So that's for the middle and lower rhomboids. So it's to create from this rolled posture to back up like this. So it's kind of that area that like your mom would tap when she's telling you like sit up in church or whatever, it's that area right there. So it's going to be pinch those blades together. So she was right, but you can at least do the work now. So that's the strengthening. So if you look at upper cross, and really the origin of that name it comes from an actual kind of a cross. So you look at the deep neck flexors, weakness here, and then weakness on the rhomboids. So that creates kind of this part. So weakness here and here, and then this part of the cross being like traps and pecs. So this idea of counterbalancing relationship. So that's the strengthening portion of it. So we want to make the deep neck flexors and rhomboids stronger, facilitated, shorter, hyperactive. So we want to turn them back on. The opposing muscle groups, these are the tight ones. This is where people, traps, levator, pec, major, minor. This is where people always have knots. You hear about it. A lot of people carry their stress. They hear like loud noise, or they get just stressed out emotionally. You'll see people kind of curl up that way. Also in Minnesota, when it's cold, you'll see people that are already hyperactive there, in their coats, and now they're more hyperactive even when they're not working. So you'll be shivering into upper cross syndrome essentially. So these areas, like I said, we don't want to make them weaker in the relationship really. We just want to kind of lengthen them and get them to be a longer muscle group. And so the traps, an easy way to do that is using a chair So now from a chair position, a lot of the people with forward head posture, upper cross syndrome, they'll have it from actually sitting in a chair. So using a chair as rehab is really convenient in this case. So again, we're too tight here. So this is that muscle that hikes the shoulders up. And so we want to lengthen that, make it longer. So I usually have people just scoot over a little bit in the very same chair sometimes that they're using at work. And especially long-armed people, you're gonna have to scoot over a little bit. And I'll just have them grab on to the side of the chair. You're gonna lean your head away and either up or down. You can do a combination, but just hold that. So you're gonna stretch, it's away and then up and or head down. So easy way to do it. Again, 8 seconds at a time, maybe 3 sets. And usually people that I train, I want them to do multiple repetitions throughout the day. So they might do 8 seconds every few hours or something like that. And then, of course, probably both sides in most cases that you come through. So you're gonna go head away and chin down or chin up. So that's the trap. So again, the traps and pec are too tight, so you want to make them longer. We get into the tightness of the chest. So easy way to do that is against a wall. Some people, the stretching of the chest, they use a doorway, and that can be effective as well. I just feel like there's some restrictions in that. So I'm just giving you my clinical pearl on what I feel like is most relevant and what works here. So pec major and minor, so we want to go hand on the wall, and we want to do below the shoulder height and then above the shoulder height as well. A lot of people that are really tight and really forward, when they put their hand on the wall, they're going to feel stretching already like in here. So you might have to get some lengthening in your forearms first, and then kind of gradually get to the chest. So I'm going to have my hands pointing behind me. I'm going to turn my body away from the wall. So here's one common mistake that I'll see people make. They're actually even doing their rehab. They maybe even are doing their rehab while they're standing in this building. And so they'll be on the wall over here stretching, but they actually internally rotate their shoulder to get the stretch that they need. That's not really what we're trying to train. We're trying to get them away from this internally rotated idea, this posture. So a better way to do it is hand on the wall and then just move your body away. Some people even tilt their head a little bit, then you'll feel a really big stretch in there. So below your shoulder height and then above your shoulder height as well. So you'll feel a different kind of pull in the chest. And again, you want to rotate your body, not rotate your shoulder into it like that. So again, lengthening, not really making it weaker, we just want to make it longer in the tug of war, the relationship between what's weak, underdeveloped, underactivated, and the parts that are hyperactive. So too tight, meaning the traps and the pecs. So that's upper cross syndrome. So again, that's the stability portion of one of the most common injuries that we see come in the clinic. It can correlate to a multitude of different symptoms for people. The degree to which you're going to have the symptoms is usually correlating to the x-rays, and so having some good films of not just is there a problem, but to what extent can help you know a lot about how far, how much rehab, how much frequency, how much duration is going to be needed to fix something like this. So get an evaluation. If you have more questions about how we came to this as a conclusion, why do we use these things and not some others, please feel free to ask. This is just my version of treating thousands of patients over the last 10 years, and just some of the most relevant, easy to teach type of rehab methods that really cover your bases for so many symptoms that you'll see every single day in clinic. Our contact information is going to be on a link, so contact us at Finish Line Wellness. There's an info@Finish Line Wellness email. If you have questions, you can email us there. Our phone number will be posted as well, and feel free to reach out. We are open to having doctors and students alike come and shadow, or even set up consults too if you have more questions about this or about the philosophy that we have, our story, or just other relevant questions to the wellness industry. So again, there's no better time. This is the time for wellness professionals. So we need to stand up, and we need to share our message and what we know, because we're an answer for a lot of what's going on with healthcare. So again, I'm Dr. James. This is Finish Line Wellness. Thanks for watching.